Thank you. Thank you for that lovely introduction and those memories. I have to say that uh, what really moves the world of science forward is people like yourself. You know, the whole area of clinical trials in ADHD and prospective follow-up studies was actually started by my mother in Montreal. There are certain countries that have had a way outsized impact on moving our field forward as compared to their resources and size. And that has certainly been true for Turkey in many areas. And in fact, in Canada, Attila Turgay had a huge influence. In the United States, also, some of the Turkish psychiatrists speaking at this conference from the United States have had an outside influence. So I think that you have a great deal to be proud of in this area. Um, you are quite correct that the study of functional impairment as an outcome has been a subject dear to my heart. And I'm going to try in this talk now to walk you through what we have done over the last 15, 20 years, not just in Canada and CADRA, but internationally because of clinician researchers like yourself who took a very different perspective. So I just wanted to show you these two references, one from 2018, which summarizes the many validation studies, clinical trials, and outcomes that have been done internationally. The point of this paper was very interesting. It was to determine from all of these studies whether we could conclude anything about functional impairments itself from all the international research that had been done. And then the theme of today's talk has been published just in the last month or two in Brain Sciences as a commentary or an editorial to explain the very concept of why this is important, which is the theme of today's talk. These are my disclosures. I am currently working on the development of digital apps for assessment and treatment of ADHD. I have book royalties. The measure that I'm going to describe, the Weiss Functional Impairment Rating Scale, which is called the WOOFers, has been purchased by Multi Health Systems. And I'm going to describe the work that they've done. The manual for that is going to be coming out very quickly, early in 2023. And then I have consulted to various pharma companies. So what I'm going to be talking about today, and this leads right off from what Mahmoud was just saying, that my hope was to capture a patient-centered perspective that moves beyond core symptoms to evaluate how the patient's emotional and behavioral problems are impacting their functioning. The development, clinical use, and the impact of this scale, the woofers, will be used to illustrate the change in perspective. What happens when you move from things like clinical trials to understanding the population characteristics of how mental health symptoms and behaviors impact how the patient is actually doing. So our learning objectives will be to identify the unique contribution of functional impairment as an outcome. What have we learned? To interpret population norms, cutoff scores, functional improvement, functional remission using the woofers. So it's really important to understand here that we often use the concept of symptom improvement. Did the symptoms get better? And symptom remission, a concept that was originally framed in the MTA study of how robust a response the patient had. Were they normal? Did the symptoms go away completely? I'm going to talk about how inclusion of functional outcomes has changed our understanding of risk assessment and treatment effectiveness. And then, as always, being a clinician researcher, I'm going to talk about how to incorporate functional outcome into clinical practice. How does this change what you do every day? Something that you can take home with you when the conference is over to make your work life that much more interesting and that much more effective and meaningful. I'm going to emphasize that by looking at functioning, not only do we get a cross-diagnostic perspective, we also get a cross-cultural perspective, and we get a perspective that is sensitive to patients who are the most vulnerable by virtue of trauma or any form of social disadvantage. So let's start with the concept of efficacy and effectiveness. Most of our research is based on efficacy. What efficacy tells you in a randomized controlled trial is, can a treatment work on symptoms in a very controlled setting, a carefully selected population, receiving systematic expert care? I have to tell you how far from real life this really is. So, for example, I spent many years doing clinical trials, developing all the drugs that we use now. In those studies, you had to be English speaking. You had to be well enough off that you could come in during the day and miss work. You had to have access to transportation. You had to be able to comprehend complex consent forms. And most of the time, you had to have no comorbidity. That represented 7% of my clinic. So we know the most about how these treatments work in perfect populations with perfect care in perfect settings that are almost irrelevant to the majority of patients we actually treat. Effectiveness is completely different. It's the opposite perspective. Does the treatment work in real life in the clinic? Not with the 7%, with the 93% of the complex patients you all treat every day who come in with 7 different disorders. And can we then go beyond just looking at the rating scale for symptoms to understand the full spectrum of the patient's outcome? We need to know so much more about the full patient population. The best study in psychiatry I have ever seen is the ACE study, Adverse Childhood Experiences. I find it totally remarkable that a study that described severe traumatic events early in life was able to predict such a wide range of medical and psychiatric outcomes, almost every outcome you could think of, decades later. What that tells us is we need to be able to make sure we are having an impact on that trajectory by which early childhood experience has such a powerful effect on later outcome. In these populations, the disadvantaged populations, symptom severity outcomes of a single diagnosis just don't tell the whole story. So I've coined a phrase. For those of you who either enjoy doing research or reading research, you know that the way we set up our research studies is we write our research protocols with a primary outcome, which is what we will look at as the most important outcome, and a secondary outcome, which is a wider spectrum. The primary outcome is the clinician perspective. It's symptoms. The primary outcome of every ADHD trial is the ADHD rating scale. The secondary outcome is all those other things we just heard about. Function, quality of life, adaptive life skills. That actually represents the patient's perspective. I would like to suggest we got it backwards. It's very self-centered for the doctor to say the primary outcome is what the doctor is interested in, which is symptoms. Because from the patient's perspective, the secondary outcome is primary. They don't care that the ADHD rating scale got better if they didn't. And that's what this work is all about. I would suggest then that from symptoms to function, from efficacy to effectiveness, the ultimate outcome is development. Can we intercede in the trajectory where early childhood experience is determining an adult outcome? And in order to do that, we know, for example, from the prospective follow-up studies, long-term functional studies, we know that ADHD is associated with all kinds of deleterious outcomes, academically, socially, marital life, occupation, education, driving, accidents, obesity, smoking, substance use, and yet we do not measure those outcomes as they are unfolding. How can we possibly impact those long-term adult functional outcomes if we aren't measuring them as we are providing treatment through the life cycle? So here are my hypotheses and assumptions. The first is a phrase coined by my mother in the 1950s when she started her prospective follow-up study, and that is pills do not build skills. And I'm going to show you data to support that. She was actually one of the pioneers of saying, we can't just look at the rating scales. We have to look at how the patient is doing. A recent study, which she was in her late 90s, was one of the authors, together with Russell Barkley and all the other authors who did those long-term studies, have shown that it is incredibly important not just to look at symptom persistence, but how many hyperactive children grown up are still impaired. Many children will experience at least improvement in symptoms, and many will experience a significant fraction, maybe a third, will experience complete remission of symptoms. But the number that experience total remission of symptoms and functioning, so that the shadow of their child ADHD is no longer being cast on their adult well-being, is actually quite small. So bottom line, I'm going to argue that symptom assessment is for sure necessary and never sufficient. It's not good enough for you to look at symptoms without understanding the patient perspective. We need to find those patients who are functionally impaired even when their symptoms get better. And I'm going to show you our data on how many patients that actually is. And then once we identify the residual functional impairment, even in the patients where symptoms are better, what do we do to provide the treatment that is necessary for that residual difficulty? I'm also going to show you data from David Cohill, one of my favorite clinician researchers, showing that if you do that, you get a very different perspective on what drugs are doing. So we classically compare drugs by saying things like, oh, stimulants have an effect size that is large. Atomoxetine has an effect size that's a little less large. Guanfacine has an effect size that's moderate. But actually, to really understand what these drugs are doing, you need to look at how they're affecting functioning. So I'm going to describe two concepts of functional impairment that are completely different and have not been adequately described in the way that I'm going to put it to you today. The first concept I'm going to call relative functional impairment. That means clinicians who are interested in impairment caused by emotional and behavioral problems. So the question asked on the woofers is not, how are you doing in school? It is not a question of trait. The question asked is, how are emotional difficulties and behaviors impacting your functioning? So it's function relative to the impact of symptoms. That is a measure of state. And unlike absolute functional impairment or disability, it is highly sensitive to change even within a week. Absolute functional impairment is based really on disability. And I'm going to describe more because, for example, Russell Barkley has created a beautiful measure of absolute functional impairment. The World Health Organization Disability Scale is a measure of absolute functional impairment. These are measures not of how your symptoms are influencing your function, but how you are doing compared to other people, which tends to be very stable as a trait. I'm also going to show you from our research that patients can very reliably report on the ways in which their emotional and behavioral problems are affecting their functioning. And then I'm going to describe our measure, the woofers, the self-report version for any adolescent or adult who's capable of completing it, and the parent version for younger children who are not developmentally capable of completing a measure, which tells you about relative functional impairment. Now, if we look at the DSM-5, DSM-5 talks about the International Classification of Functioning and the WHO-2, the World Health Organization Disability Assessment Scale, which is simple and can be scored by computer and is become a standardized scale applicable to all health conditions, but not specific to mental health, and it's very much a measure of disability. It is a measure of function, has nothing to do with how your psychiatric or mental health is impacting your function. Since the DSM-4, where all of us had to rate Axis 5, where we had to at least think about the global assessment of functioning or the CGAS, I think we've really lost sight of incorporating functioning into our diagnostic system. And when the DSM came out, it said for all its diagnoses, you have to have a measure of how these symptoms are causing impairment in two different settings. And then it doesn't tell you anything about how to do that. That's like a DSM for ADHD saying you have to show that the patient has problems with attention, hyperactivity, and impulsivity, and not saying anything about how you measure that. I think it is so important that there is now a recognition of the importance of looking at this in the patient-reported outcome measures that are being developed in the PROMIS system, which are incorporating functional outcome. So best practice objectives, routine assessment before and after treatment of number one. This is what I teach. This is a measurement-informed care article that I recently wrote, where I put forth an idea which I think is really important, and I'm trying really hard to teach my child and adolescent psychiatry trainees to do this. And it's remarkably difficult. Before you give somebody a Vanderbilt to rate ADHD, please do a differential diagnosis. So one of the measures we developed at Cadre, which is used all over Canada, it's so easy and it's so helpful, takes all the DSM-5 disorders. It actually only takes about 5 minutes to complete it. But before you hone in and give a disorder that scaled specific to a disorder, make sure you know what the patient has. Because for the majority of patients, it's not just ADHD. So you have to know what else is going on. Then, of course, we have our disorder-specific scales. And then lastly, I would argue that you have to look at the functional impairment to define the targeted problem that is then going to inform the treatment plan. Early intervention in ADHD is forever. That's not just true for ADHD. My favorite talk I ever gave was I was asked to give a talk on autism. And everybody knows that the mantra in autism is early intervention. As though with autism, if you diagnose at 18 months and provide early intervention before the age of 3 and do intensive applied behavior analysis, you've done everything you have to do, and when they're 18, you don't have to intervene anymore. That is just not true. What I would argue is early intervention is forever. If you do that with a toddler, you set them up for their school years. If you do it during latency, you prevent many of the problems that may emerge when they go to high school. And if you intervene in late high school, you prevent the period that is absolutely, from my point of view, the period of greatest risk, which is early adulthood. If you want to focus on early intervention, focus on the age of 18, because that's when they have to work. That's when they have to develop the life skills to live independently. That's what's going to decide their ultimate education. So in fact, early intervention is a process that endures throughout the life cycle. What is true for autism is just as true for ADHD. The autistic toddler who was diagnosed and got ABA and then didn't get anything at 18 is going to spend the rest of their life living in their parents' basement until their parents die, and then they have to be supported by the state. The same exact thing is true for ADHD. We know that many of the long-term outcomes will be prevented if, and we know this from the Scandinavian studies, if intervention is started at least before the age of 9. But if you, and this is the MTA result, if you provide great intervention between the ages of 9 and 12, and you don't provide intervention in adolescence and early adulthood, it makes no difference. They drift back to where they otherwise would have been if they had never been treated. For people, the reason development is so important, and this perspective is so important, is because the the essence of how a patient is doing is dependent on the intersection between their skills and the demands of the environment. The demands of the environment in kindergarten, where there's somebody watching you all the time, are very different to the demands of grade 12 or grade 13 when you're 17 years old and you actually have to organize yourself and nobody's watching. And there's lots of temptation to do things that are very risky. So that's the intersection we need to focus on. When someone has a mental health condition, whether it's autism or ADHD or any neurodevelopmental disorder, where at that stage of the life cycle, they cannot meet the demands that are being placed on them, it's very depressing. And that's what lies at the root of a lot of comorbid depression and anxiety. And the way to remediate that is to bring the demands in line with the potential of the patient. That's critical. And you can't do that if you don't know what those demands are and the extent to which the patient is meeting them. So this measurement of functional impairment is critical to the prevention and to the treatment of secondary depression and anxiety. This holds the potential then for us to actually remediate and mitigate the debilitating long-term outcomes we see in the prospective follow-up studies. Now, we talked about how the Woofers was developed as an ADHD-specific functional impairment rating scale. The way it was actually developed is I sat in my office all day long for a few months with a yellow pad of paper and a pen. In those days, we actually did use paper and pen. And every time a patient came in, I listened to what they said, the headlines. And what they always came in saying was a problem. So I developed a long list of the problems that were the patient's chief complaint. It was from that list that we gradually developed the woofers. It turns out that there are only so many problems a patient can have. And by developing a list of problems for patients with ADHD, it turns out it's not ADHD specific. So we now have validation data. We know it's really good in ADHD cases, but turns out it's just as good for medical disorders. It's just as good for depression. It's just as good for autism. And in fact, when used in each of those clinical groups, everything makes perfect sense. When you test the woofers in a depressed population, the most important difficulty is self-concept. When you test the woofers in an autistic population, the most important deficit is social engagement. So we can, in fact, now extend the woofers to other disorders and thus be able to obtain not only comparisons between treatments, but also comparisons in the functional impairment associated with a particular disorder. If we look at functional impairments that we find to be specific to ADHD, we have already learned from previous woofer studies that the key outcome that is a consequence of not paying attention is learning. The key outcome of impulsivity is going to be high-risk behaviors. And the key outcome of hyperactivity is not just being disruptive, but the constant feeling of restlessness. I learned this from a patient who was an adult, and I was looking for functional questions to ask him that might get at whether he was hyperactive, because in adults, the hyperactivity goes from what it is in toddlers, gross motor movement all over the place, spinning around, to micro movements, fidgeting, twitching, biting your nails. So it's a little harder to see hyperactivity. So I asked him, what does he do with a red light? And he said, oh, Dr. Weiss, thank God you asked me that question, because that's something I'm really good. I always check for a policeman before I run the light. I never forgot that, because that's hyperactivity, that pressure to move. And it's not just physical movement, it's speech, it's activity, it's the next step. So, is functional impairment disorder specific? The International Classification of Functional Corsets for ADHD has been an initiative by the World Health Organization that has tried to define internationally the ADHD specific functional impairment. And I've given you a couple of citations of what they found. Measurement of symptoms and functioning is also necessary for psychoeducation. If the clinician perspective is symptoms and the patient perspective is their problem, and the two of you are going to talk to each other, you have to explain how the symptoms, all those 9 items of attention, those 9 items of hyperactivity, impulsivity, are actually causing the problem they came in with. So they came in saying, I don't know why my child has no friends. He never gets invited to birthday parties. And then you show them the rating scale, which is all marked 2s and 3s, and they say, what does that have to do with the birthday party? Explaining that connection is one of the most therapeutic things we can do. In addition, when you identify specific domains of functional impairment, that is what allows you to choose appropriate treatment. So if you find out, I talk a lot about sleep, that sleep is a problem, then you can provide a sleep intervention. If you find out that friendships are the problem, the child who isn't invited to the birthday party, maybe social skills training will be the solution. If you find out, which is happening more and more, that this child is waking up in the middle of the night because he's addicted to screens, and in fact, all he does is screens, and it's causing a lot of crazy rages and aggression when you try and take the phone away, then screen time is the target for intervention. So it's the function that is not resolving that determines how we target what we're going to help with. This is the Barkley Functional Impairment Scale, and I'm bringing it up here to show you the difference in finding out about absolute functional impairment, which is a measure of trait, like the WHO does. It indicates disability relative to clinical and normal populations, and you can see that it's defined not by a 1-week or 2-week impact of symptoms on functioning, but a stable, at least 6-month period. Completely different idea. And there are 15 domains of impairment. This is still very useful, but it's a completely different question. It tells the patient overall in their life their areas of strength and weakness, but tells them a lot less about how you can intervene effectively with symptoms to change what is in fact a core trait of who they are. So I thought I would show you pictures of the woofers, and this is actually taken from the CADRA website. And what we did is we produced a PDF in which the patient clicks on these buttons, and then the measure itself will calculate the mean score. The reason it's so important to calculate a mean score is because not all things are relevant to all people. So, for example, when this scale was normed in China, at that time, the item, how do you get along with your brothers and sisters, was largely irrelevant to a lot of Chinese children. If they scored that as not a problem, then it made them look much better than they actually were. The correct answer is that it's not a problem because it's not a possibility. It's not relevant. So we want all the answers to be appropriate to that individual for our assessment of functional impairment to be personalized and individualized. You can see here that the measure looks at relationships in the family. It looks at school. And at the time that we first developed the scale, we thought school was a setting. We thought it was one thing. But multiple factor analyses done in different countries clearly demonstrated that actually school is two completely different things. School is learning, which is going to be mainly determined by attention, and behavior, which is going to be much more determined by hyperactivity and impulsivity. Of course, behavior is going to impact learning if you're out of the classroom. In addition, we were very interested in life skills. There is a great study that demonstrates that in the ADHD population, life skills are extraordinarily behind. A normal intelligence individual with ADHD has life skills that are in the range of the developmental delay. It is easier to teach a child with an IQ of 70 to routinely brush their teeth every morning than it is to teach a 17-year-old with ADHD with an IQ of 110 to brush their teeth every morning. So assessment of life skills, and remember what I said, pills don't build skills, is going to require you knowing not what they could do, but what they actually do, which is measured quite nicely on the ABIS. Then we look at self-concept, we look at social activities, and we look at risky activities. Now, it's only because I'm a clinician over and above a researcher that I included risky activities, because the psychometrics of how the scale functions works perfectly for everything except risky activities, because risky activities represent relatively rare but very salient and important events. So maybe you don't get involved with the police every day, but you only need to be involved with the police in a serious way once for it to have a major impact. As a clinician, I knew that understanding what the patient was doing that was dangerous was extremely important. And I knew that if that wasn't on my scale, I would be missing out. Because not only are these the high impact items that are going to determine the long-term outcome, they're the things I'm most likely to miss in a clinical interview. In addition to the parent rating scale, we developed a mirror image scale for adolescents and adults. The self-report by adults is extremely helpful, and everything I just told you is just as applicable to the adult population as to the child population. What's most interesting, however, is how incredibly useful this is when you're treating adolescents. Because what adolescents tell you about their functioning is completely different to their parents. The adolescents tell you they're smoking marijuana and skipping school. The parents tell you that they're not doing a good job of cleaning up their room. So it's by gathering both sets of data that you get the full perspective and that you're able to show and explain to the adolescent with their parent the differences in their perspective. Just like we measure school in both the child report and the adult report, in the adult report, we also include work. And just like school is very sensitive to treatment, work is one of the most responsive domains to intervention. This is some of the work that was done in Turkey. It's really special. And I think it's been a particular source of joy for me that, as was mentioned, some of the work done in places like Turkey, Iran, Japan, China, early on, recognized the importance of this kind of understanding. And I've asked to give you the website for you to get access to this scale so that you could continue to incorporate it in your practice. So, in summary, then, we have a self-report and a parent report that looks at the impact of mental health on actual functioning that is validated now across clinical, research, and population settings. We have norms for how people are functioning in Iran as compared to Canada, as compared to the United States, and various other countries. And that is really interesting to me because although they're not that different, some things are quite different. Some norms in Turkey are quite different to what you see for functioning in inner city areas of Chicago. The measure is adapted to the individual and provides clinicians with domain and setting specific information that's highly sensitive to change with treatment, so you can actually see the impact of what you're doing every time you see the patient so that you can prevent the long-term functional outcome. One of the things that distinguish the development of the woofers is we deliberately try to leave symptoms out of it. To the extent that we could, it's meant to emphasize just functioning, and that makes it possible to compare a symptom measure to a functional measure to look at how well they're correlated. And in general, that correlation is moderate. There are broad but individualized outcomes, so many of the things are relevant to everybody, but some things that aren't are not going to be included. There is a research impact on this. We can look at outcomes in adolescent studies. There's only a handful of adolescent clinical trials between the self-report and the parent report, which look completely different. We can compare across domains. We can compare across cultures because this measure has now been translated into at least 25 translations. I don't think I can keep up with the translations. And most important, there are 9 cross-cultural validations, the psychometrics of which are very, very similar. So this holds up in terms of the psychometrics wherever you use it. And these culturally sensitive outcomes are then very important in our work with disadvantaged or immigrant populations, because trauma, which is so powerful, is cross-diagnostic and requires assessment strategies that target intervention that move beyond categorical diagnosis. I work in a safety net hospital in the United States. That means that the patients have less insurance, and so they're all looked after in a particular place. My patients coming in don't just have ADHD. They have ADHD and depression and anxiety and learning problems and tics and a whole bunch of other things. So diagnosis, I had a patient last week that had 9 diagnoses. I didn't know what that meant anymore. And this gives me a perspective of being able to give some meaningful feedback that goes beyond saying you have 9 diagnoses. There are 2 ways to score the measure. And in the Canadian version, where you get the mean score done for you automatically, it's much easier to use the research validated criteria. but it was a great surprise. We developed a clinical way of measuring this, which works incredibly well. Any domain, so let's take family, in which there are at least 2 items that are rated as 2 or moderate, or 1 item that's rated as 3, that domain is a problem. So the way I like to say it to children is that if you take 1 item, for example, um, uh, being able to finish your homework, you take 1 item, you can say it's not a problem. A score of 1, a little, or sometimes means it's a small problem. You notice it, but it's not a big deal. A 2 would be, it's a problem. You are aware of it. And a 3 would be, it's a big problem and it's causing you trouble. Okay. That rating turns out to match. This was a real surprise to me because that's just based on clinical intuition. Turned out it matched the research ratings very nicely. In developing measures, it is now the standard to look at the minimal clinical important difference or minimal important difference, which is defined either as a standard deviation of 0.5 or by studies looking at where the patients see some change. And the minimal important difference is the clinical change that matters. And on the woofers, it's a mean score of 0.25. By contrast, a cutoff is at the end of treatment. Did the patient get to the point where they're no different to everybody else? The way in which their emotional and behavioral problems is affecting their functioning is just the same as anybody else. So in one of the papers that I gave you, we looked at 5 investigations of the parent rater, the 3 investigations of the self rating, 1 that used both. This comes from all over the place, even Thailand. Using the measure in clinical trials and clinical settings, it's grown exponentially as an outcome measure, and with very diverse populations. We have now done a very large population study in North America, looking at over 3,000 parent reports and over 3,000 self-reports to get good normative data. This is not a supernormal population. This is a population that includes the same number of clinical people that you would otherwise expect, and as a result, includes many individuals with ADHD, which is how we found out the outcome on the woofers of depression, autism, and other disorders. And what you see here is what's coming out in the manual in January 2023. You can look for any one of the domains that I described to you and look at both age and gender and find out exactly where that patient stands in terms of whether they're in the normal range, in the at-risk range, or clinically impaired, defined by their T-score, with clinically impaired being a score 1.5 standard deviations over the norm, or a T-score greater than 65, normal being less than 60, and at-risk being between 60 and 65. And this is for the self-report, and you can see that we gathered data for you. And what's remarkable here is that the measure holds up developmentally. The numbers for 12 to 13 are not that different for the numbers for people over 70. But this means you can take these tables now and get this data for your patients and then look at their change. So what did we learn from all of this that informs our understanding of the nature of functional impairment itself? The population study replicated the data we had obtained previously that uses a technique called receiver operating characteristics and tells you what should be the cutoff. What's the number that you use to define normal? We also looked and found that there was a lot of consistency between functioning in one area, one domain, and another area, and between the age groups. And the a priori clinical classification that we described, where you just look at the measure with the patient and say, oh, look here, you describe two things as being a problem, and on this domain you describe one thing as causing you a lot of trouble. It works just as well as the research criteria. What you find is the mean of most domains is sometimes in the ADHD population, and that's 2 standard deviations across different to the control population. And there's quite a lot of consistency between each of the anchor points being about a half a standard deviation. And different items within a domain, particular item, actually will represent what Ross Greene with his collaborative problem solving would have described as a lagging skill. There's a high correlation between having problems in one area and having problems in another area. It's also true that there is remarkably high internal consistency, remarkably high for the total score, as well as moderate correlations between the domains. That came as a surprise to me. I liked the idea that there wouldn't be high internal consistency, that most of us would be doing really well in some areas, but having trouble in others. Actually, when you're doing well, you tend to be doing well across the board, and the converse is also true. Risky activities, as I mentioned, has distinct psychometric properties in which the mean score, of course, is going to be lower. So the mean score for all the other domains tends to be the same. But when you're looking at something that's relatively rare, the mean score is going to be lower. But nonetheless, engagement in high-risk activities does present a risk for other difficulties. The other thing that came as quite a surprise to me, and is incredibly good news in terms of what I talked about, prevention of long-term functional outcomes, is that to my tremendous surprise, even though risky activities are rare events that are very important, treatment of the ADHD symptoms has a big impact in preventing risky activities. The scale is highly reliable. You give it one time and you give it 2 weeks later without any intervention, you're going to get the same score. That means that patients are very reliable in what they're reporting. They understand what we want them to tell us, and they're doing it very reliably. And we also found out that if you don't do anything, you just look at a naturalistic population, this is stable, which means that when we see robust improvements with treatment, it occurs against the backdrop of relative stability. And perceptions of functional impairment between self-report and parent report for the adolescent population, or there was a measure developed by Canu to get collateral for adult report. Perception of impairment by different people with different perspectives can be widely different. So David Cohill, I use this as an example, looked at how functional impairment outcomes in clinical trials varied with different medications. This is a great way to show you why this is important. So what we see here is the outcome for those functional impairment domains, looking at lisdexamfetamine in the black bars versus placebo in the gray bars. And we can look at the effect size. When you treat with a robust amphetamine, the effect on family is large. The effect on learning and school is very large. The functional impact in double blind over a short period of time has an effect size of 1.2. The impact on life skills, 0.2, small, almost negligible. Self-concept, not significant. Socialization and risky activities, high moderate. So what this means, if you do this study and you get these results, you're going to think this patient is all better. And their family and their teacher reports are going to show that they're better. But if you don't help them with their life skills and how they feel about themselves, maybe by giving them training in life skills or maybe by giving them psychotherapy, there's important parts of their life that are not going to get better. This is the same kind of analysis for a different drug, and I understand that you're going to be seeing guanfacine launched in Turkey next year. And we know that the profile of response to guanfacine is somewhat different. It does help with all aspects of ADHD, but the effect size of the symptom response is more moderate. And what we're seeing here is moderate effects on family, learning, and school, moderate effects on social, and very modest, not significant effects on life skills, self-concept, and risky activity. So here you see when you use the measure and you include it in your outcomes, the differences between different drugs actually targeting very different things and targeting different domains of impairment. When we measure outcome, we do it two ways. One is how much did the patient get better from how they presented when they first came to us. That is change from baseline. And it's what I refer to as a minimal important difference. It's a measure of percent change. It can be 25%, sometimes it's 30%, sometimes it's even 40%. You can also measure at endpoint how they did. Did they reach a T-score where they weren't any different to the rest of the population? You absolutely have to do it both ways. Because if a patient comes in and they have a very little problem, the change is going to be small because they don't have that much difficulty. And the endpoint will be normal. But if the patient is very severely ill, you may see a very large improvement and they're still quite sick at the end. So it's only by looking at both change and how they were at the end that you capture the full perspective of the patient. So we define improvement as percent change, and we define endpoint as remission. They are, in fact, quite different. Remission means you're the same as the normal population, and it's quite a robust measure of change. To really get at this, we studied how many of the patients who were doing well symptomatically actually had functional change, and how many of the patients at the end of treatment who had no symptoms were functionally in the normal range. And what we found when we looked at the relationship between symptom improvement and functioning as an improvement is only half the people whose symptoms get better actually have shown improvement in their functioning. Those are our most important patients. If we say it's the end of the road when they come in and their ADHD symptoms are better, and we don't check if their functioning has gotten better, then half our patients are going to go out the door still just as impaired as they came in. This then is what we found when we looked at endpoint and remission. What we found was remission, defined in ADHD as a mean score less than 1, or a Woofer score of less than 0.65 at the end, or normalization. At the end of open label, 75% of the children just as what Josephine Elias said, our treatments for ADHD work really well for symptoms. At the end of the day, 75% of the children didn't have ADHD symptoms. 81% showed functional remission. That meant that 1 in 5 of our patients who didn't have even a smidgen of ADHD symptoms left were still having functional problems. The clinical implication of this is that if you don't measure outcome, you're going to fail to provide targeted intervention where the rating scale for ADHD symptoms improved and the patient's problems persisted. If you look at just stimulant outcomes, you feel really good because 90% of your patients are going to get better sooner or later. But if you say, real improvement is just not what I see, but what the patient sees, and you define remission the way Joe Biederman did, that both symptoms and functioning have to improve, you're going to find that after you do a perfect job of treating the ADHD, only half your patients meet the criteria for symptom and functional remission. Residual functional deficits in treatment are common, impairing, and often treatable with targeted interventions to address that particular impairment when you know about it. So in conclusion, characteristics of functional impairment are consistent across cultures, languages, countries, research settings, clinical settings, population settings, disadvantaged populations, and more advantaged populations. And domain-specific improvements are going to vary with different treatments. Multiple informants have different perspectives depending on their exposure to that domain and their expectations. Adolescents think their room is clean, and parents don't think so. To know that and provide that feedback, you have to measure it. Functioning is relatively stable, but it is incredibly sensitive to change with intervention if you have a measure that looks at how the symptoms impact how the patient is doing. And when the rating scale improves, always remember your patient, you need to ask, your patient may still be struggling. It's only with the assessment of both symptoms and functioning that we can identify those patients who are still impaired when ADHD improves and determine what domains need continued intervention so we get both symptom and functional remission that will, in the long term, with development, prevent those deleterious long-term outcomes. So the physician says, I hope this patient has what I treat. I use stimulants, I treat ADHD symptoms. The patient says, I hope this doctor treats what I have. I can't function. And I say, optimal treatment begins when patients and clinicians arrive at a shared explanatory framework to understand how symptoms reflect disorders that impact all the various domains of impairment. Thank you. Our hope is that a routine reporting of both symptom and functional improvement and remission will eventually give us a much more nuanced appreciation of the extent to which treatment has addressed the patient's concerns and to identify those domains of functioning which are more sensitive or more resistant to medication treatment, because ultimately that's what counts. Thank you.